I'm Dr. Erin Michos. I'm the Associate Director of Preventive Cardiology at Johns Hopkins. I'm really thrilled to be here today with Dr. Schuyler Jones, who's one of the co-principal investigators of the ADAPTABLE trial presented at the American College of Cardiology late-breaking clinical trials. So Dr. Jones, this is a really important question because every year over 800,000 Americans have a heart attack. And when we look at the past literature, there's been variable results in terms of what's the right dose of aspirin. Most of the prior studies have been observational. So ADAPTABLE is hoping to answer once and for all, what is the optimal dose of aspirin for secondary prevention among patients with atherosclerotic cardiovascular disease? So tell us what you found.
Thanks for having me, and I'm excited to be here to discuss ADAPTABLE. So as you probably know, ADAPTABLE studied over 15,000 patients with established heart disease, and we enrolled those patients at 40 centers in the U.S. We followed them for about 26 months, and the primary results showed that there were no differences in the primary effectiveness or primary safety endpoint between the two doses, 81 milligrams and 325 milligrams of aspirin.
I'm interested in maybe any subgroup analysis that you might have done. There have been prior studies suggesting a variability in aspirin response by body mass index, by presence of diabetes, or by sex. Did you find any differences across subgroups?
We had multiple pre-specified subgroups, and we continue to look at each of those, and we'll plan to analyze them over the coming months. But the kind of top line results, the top line forest plots showed no differences or similar treatment effect across the subgroups, including weight, including age, race, sex, presence of diabetes, and kidney disease.
Well, I think that's really important. That's really reassuring to know that maybe, low-dose aspirin is just fine for secondary prevention. So ADAPTABLE was randomized, but it was open label, and I was just something that could invite criticism. I was just wondering about the open label part, if you thought it influenced at all about the results and whether there was any difference in adherence between the two groups.
We definitely set out to do this trial differently, and by differently I mean we enrolled people at 40 centers, but we didn't actually have study visits. So unlike traditional studies, patients didn't come in to do enrollment visit. They didn't come in to do follow-up visits. So everything could be done remotely or via the patient portal, which was internet-based. And so that's the way we wanted to conduct this study and to kind of shift the paradigm and go direct to participants, involve patient partners, and do it in a more streamlined fashion. And so in doing that, to actually answer your question, in doing that, we didn't think that a double-blind approach would be feasible, especially because this is a decision that patients make every day when they purchase over-the-counter aspirin. And so we knew that there would be challenges with that, and I think like any open label study, adherence to the study medication or to the dose is important, and so we were prepared to deal with that.
Well, what I'm fascinated about, even more beyond the aspirin results, is really the unique trial design of ADAPTABLE. It's really unique for a cardiovascular outcome trial of this scale, and I really think it could set the stage for how we redesign future cardiovascular outcome trials. The traditional ways of recruiting, following participants, ascertaining events is very burdensome and expensive. And so this recruitment is, very unique, directly to patients. You could reach thousands of patients in a single day because patients were identified through electronic medical records. So I wanted to talk to you about recruitment, because as trialists, we know this is usually one of the largest hurdles of clinical trials. So what was your response to the electronic invitations? What was your response rate? And then my second part of my question is a topic I'm very passionate about, is how to improve diversity of women and minority in clinical trials. And did this methodology of recruitment overcome some of this? And what was your enrollment by sex and by race ethnicity?
So the first question is about the overall approach and enrollment. So we identified 650,000 people with heart disease who are eligible for the study at 40 centers and one health plan in the U.S. So I think that's an accomplishment in itself. We actually reached out to 450,000 patients who were eligible. Of those, about 50,000 actually visited the patient portal to look at the study. About 32,000 used a linked or personalized access code, which linked them to the electronic health records at their participating institution. And then 15,076 patients joined the study. And so it was a big, broad approach strategy. And we made a lot of efforts to really improve diversity and be inclusive in the study. And I would say that we probably mirrored what we see in traditional studies. So 32% of patients were women in ADAPTABLE. So we obviously would have liked to have had more participants be women, and 9% of participants were identified as Black or African American. So again, would have liked to have had a higher percentage of a more diverse population in ADAPTABLE. I think the last part of your question was, how do we do this better, and does the method of approach or the method of identification make a difference? And I think it probably does. And I guess if we rely on technology, that may be something that could be useful, but we have to make sure that we utilize different aspects of a recruitment strategy that speaks to patients of all ages, race, and gender. And so we have a lot to learn. We have a lot to do, but I feel like we made a good effort, and we learned a ton about this.
Yeah, I really think it sets the stage about how trials might be done in the future. And the one last thing I want you to comment on, which I think was really important, is that I believe you try to do a patient-centered design. My understanding is that you had patient representatives known as adapters that were actually part of your trial design, your steering and executive committee, and making sure that patients' voices were heard in the input and conduct of the trial. So I didn't know if you had any comment about involving patients in trial design.
Yeah, I could probably talk for days about this. We had 9 patient partners, as you said. They called themselves adapters, and they're involved in every aspect. Honestly, they looked at they reviewed and revised the protocol to begin with. They looked at patient-facing materials. A great story actually is we showed them recruitment materials, and at some centers you had to be very traditional. You actually had to put it on a white piece of paper in a white envelope with a university logo on it. And they looked at it and they said, that looks like a bill that I would get from the hospital. Why would I open that? And so using some input from them, they designed colorful brochures with pictures on it. And honestly, to get back to your kind of diversity question, a couple of our adapters said, you know what, these pictures actually don't resonate with me. We need to actually make this be more inclusive. And so we created 4 or 5 different versions, and I think that was part of our learning and part of our process. But again, I think it's probably just the beginning as we recruit a diverse population in studies like this.
Well, this was just really fascinating, and again, I think it's a whole paradigm shift about how we might be conducting trials in the future. So I want to congratulate you, Dr. Jones, and your colleagues for really a remarkable study, and thank you for your presentation and for speaking with me today.